Hello, everyone, and welcome and thank you for joining the 30th webinar in our Pandemics in Society series. Today's topic is Bolstering Africa's Children's Hospitals. I'll now pass it to our moderator, Wilmot James, Senior Advisor to the Pandemic Center at Brown University School of Public Health. Wilma?
Hello, everybody. From wherever you are, it's good morning, it's good afternoon, it's good evening, and a warmest of welcome to our discussion today. My name is Wilmot James, and I'm a professor of public health and senior advisor to the Pandemic Center at Brown University, and it's my great pleasure to moderate today's panel. So, colleagues, in the wake of a landmark study recently published in the Public Health of Science Global Public Health, otherwise known as PLOS, we are faced with a stark reality and challenge today. The children's hospitals responsible for the caring of this generation of population today in Africa are stretched, they are strained, and in many places simply not equipped to meet the needs of the children they serve. The Children's Hospitals in Africa Mapping Project, known by its acronym CHAMP, is the first and the most extensive survey of its kind to date, across covering all of sub-Saharan Africa, assessing 20 major pediatric hospitals and centers in 15 countries. The data paint a very challenging picture. The foundational infrastructure required to deliver safe, high-quality pediatric care is dangerously inadequate. Many hospitals are at breaking point. Joining us today are two experts in pediatric care who also co-authored this important new PLOS study. So first of all, I'd like to welcome Workabiba Abebi Taya, who's a professor and consultant in pediatric infectious diseases at Addis Ababa University in Ethiopia. And then next, I'm pleased to welcome Ashraf Hassan Kubadia, who's an adjunct professor and academic head of pediatrics and child health in the School of Clinical Medicine at the Faculty of Health Sciences at the University of the Witwatersrand. I'd like to remind the audience that during our discussion today, you're welcome to drop questions into the chat. I'd like to encourage you to do that as we go along, and we'll get to them as soon as we can. So let's get into this really important discussion. And let me start by asking Ashraf the following questions. How were the hospitals selected or the centers selected? And are they representative of the hospital services for children in these countries?
Thanks very much, Wilmot, and I really thank you and the organizers for inviting me onto this important webinar. So to get to your question, these were highly selected hospitals. They were selected through essentially the research team at Columbia that embarked on the study, reaching out to colleagues on the continent that were at academic centers, usually hospitals affiliated with the university, and then snowballed to involve many other centers. So they were essentially the academically affiliated hospitals, and I would say a really biased sample, not really reflective of all children's hospitals in these countries. And I think we will get into possibly, the makeup of these hospitals.
Thank you very much for that. Yes, so there was a selection process, and thanks for describing how that worked when it came to the original start of the study by the Columbia University team. So here's the next question to both of you, starting with Abiba. So the study, as you know, focused mostly on children's hospitals that were among the best in their particular regions. So how can we expect health facilities in both urban and especially rural areas to treat young patients during an outbreak that could occur anywhere? Workabiba, you need to unmute, Workabiba?
Yeah. Thank you, Prof. Wilmot. And I want to thank also the organizers for having me and also having this interesting discussion. So I think, as already my colleague says, these hospitals are best of the best hospital in this continent. So especially in the eastern and southern part of Africa. So you can imagine, or it might not need an intelligence to guess how the rural part of these countries, the healthcare system in the rural or in district hospital or in any urban setting to be, because even this hospital, the healthcare system is so much constrained, and so we can guess that the rural part will be health system maybe more severely constrained and overcapacitated. And in fact, how can these district hospitals and also healthcare facilities in the rural setting can manage giving health services for children? Maybe they are referring patient whenever the patient is critical. So that will fuel the burden already, the overstaffed and overly stretched services. So, or they might do the service in a compromised way.
Okay, no, thank you very much for that. And since you're based in Ethiopia, I would presume that there'll be some difficulty, especially in areas that are going through difficult political times as well, in terms of that network.
Yeah, even the patient, even if the patient is referred, it sometimes may be difficult for the children to come to these places. So you can imagine how the problem will be in a rural or in district hospital.
Thanks. So over to you, Ashraf, on the same question.
I mean, the study was really aimed at looking at how prepared these hospitals would be in the face of a big public health threat, such as a pandemic. And, this was done in 2018, 2019. And even then, what we found is that they were woefully inadequate to meet the challenge of any major emergency, because they were essentially operating then, and we suspect even now, at near capacity, and over as my colleague Beba said, kind of overstretched. So very ill prepared to deal with public health emergencies.
Thanks very much. So, Ashraf, since you're speaking, this survey was completed before COVID-19. So it's reasonable to assume the situation would have probably worsened. Beyond the pandemic itself, what other factors are contributing to the decline in capacity and quality of care, such as, for example, reduced external funding, given the current environment globally, and also climate-related pressures, which are clearly building up in ways both predictable and in many ways unpredictable?
So, I mean, as you said, I mean, I think that's the biggest shock now after COVID for us on the continent, is many of the hospitals and services were recipients of USAID funding, for example, and that's being withdrawn quite dramatically. And so that's going to have an impact that we will start to see the effect of in the months and years to come, with rising, in many different ways, rising rates of infection, whether it's, HIV or TB, malaria, that sort of thing. But as you've mentioned, climate change is also one of these major threats that is going to erode the capacity of these hospitals to cope, because they weren't really, I think even in the best of times, these hospitals are functioning in a very constrained way in terms of resources. And when you have healthcare, climate change kind of shocks, heat waves, for example, or floods, this just disrupts hospital supply lines, and it's likely to make things much worse.
So there are routine sort of climate issues, changing rainfall patterns, which changes the ecosystems for disease vectors, increasing temperature that you mentioned, and then extreme weather events, which are highly disruptive. So do you have a sense of which ones are placing these hospitals at greater risks compared to others?
Yeah, it's difficult to kind of weigh up these one against the others. I mean, we've seen increasing that. Perhaps I'm talking because of in our region in Southern Africa, we've seen in recent years quite a number of floods. In fact, even in South Africa, Mozambique, Zimbabwe, massive or very disruptive on the floods that have really cut off people from healthcare services, but essentially shut down healthcare services apart from just reducing access. So those are kind of those, catastrophic events. In terms of the more chronic problems where we're seeing rising rates of infection, those are yet to be kind of quantified. I mean, certainly they're happening, but because when the literature is reporting changing, as you said, ecosystems, but we're yet to kind of quantify its impact in our hospitals and what it's doing to our services. So what I'm saying is that the extreme weather events are the ones more easily identifiable whereas the other ones are certainly happening, but much harder to kind of quantify.
Thanks very much, Ashraf. We'll return to that subject. So I wanted to ask Worker Biba to talk about children that are at greater risk developing infectious diseases compared to older patients in the region. And so why is it important to prioritize resources for children even when other groups face higher death rates, higher mortality?
As an infectious disease specialist, really, this question would be to the right person. Children are more vulnerable for infection. Even their age makes them vulnerable because their immune system is not mature. And they are usually like when they go to the daycare, the overcrowding, and also like in a place where sanitation is a problem, and also safe water supply, which can directly link to the infectious disease causes will increase. And there are also several factors make the children more vulnerable for infectious diseases. And when we see the services in this region, like most of the hospital, like this 20 hospitals, when we see the service, they do have like 172. The median bed is 172, which is a decent number, but these 172 bed numbers are mostly occupied. So when we see the median bed occupancy, it's more than 90%, like close to 94% in most of the hospital. And any bed occupancy greater than 85%, we can say it's functionally full. And most of the diseases in this hospital are infectious disease like malaria, acute respiratory disease, diarrheal diseases, with underlying cause of malnutrition. So all this leads to infectious disease burden, which most of the time are severe and also like devastating, and these children may stay in the hospital for prolonged duration, and that will also compromise the health services in this hospital. So, like in areas where I live, infectious disease are the most common causes of morbidity and mortality in these children. And also they are the most cause of bed occupancy in this hospital. And like most of the disease can be easily preventable, but unfortunately still the major cause of morbidity in this region.
I mean, that should focus our minds, right? So they are preventable diseases. And so you're looking at unnecessary death among children. So that's quite a thing. And it's not just a technical science or medical thing, it's a moral thing. Because when things are preventable and we have the systems and means to do that, why are we not doing that? And here we're talking about overcrowding when it comes to bed space. When which is a question of the built environment, the size of hospitals, and then the equipment that's placed in it. That's a resource. That's not, in the broader scheme of things, that's a very small expenditure that could save lives of children. So that should really focus our minds. So Ashraf, could you comment on this issue with regards to South Africa and Southern Africa?
Yeah, sure. I mean, it's not too different from what Wakabeba said about Ethiopia in terms of the bulk of the bulk of the admissions that you see in our hospitals are also infection related. Many are also associated with malnutrition. We don't see as much malaria except in some parts of South Africa, but for the most part, we don't have malaria, but we have we used to have a high rate of HIV. It's much less now, but we still see lots of acute respiratory tract infections. We still see TB. So these infectious diseases are still the bulk of the inpatient kind of admissions. But I think it also points the fact that they're coming to these tertiary hospitals, the ones that we surveyed, which are the sort of so-called top of the top hospitals and your tertiary centers, kind of points to a failure of being able to have these children admitted at district and other hospitals, which could manage these. These are not cases that can't be managed at lower levels, but the reason they're coming up is essentially what I think the study is pointing to is a lack of funding overall. If there's a lack of funding at these top tier hospitals, you can imagine that the lower level hospitals, secondary level hospitals, district and rural hospitals are even less resourced and therefore less likely to keep even basic. These are sometimes patients that could, essentially stay at these hospitals for a couple of days and then be discharged, but they move up the system and then flood the tertiary. So South Africa is not much different from the rest of the continent in that regard.
Okay. So I was part of the team joined by Columbia professors. This is Larry Stanbury and Phil LaRussa, when we visited many of the hospitals, and we saw across the board health workers, so the physicians and the nurses and all the aides doing their very best, going way beyond the call of duty to save lives. I mean, it was quite remarkable to see that level of commitment under working conditions that I would not call desirable. Right. So you've got hard-working health professionals at it, saving lives, but under the most challenging circumstances that are so basic, that it wanted to make us cry, right? So very basic.
The odds are stacked against you.
So this is the message to the policymakers when you design a health budget: is why you're allocating your budget in the way that you are. They're not saving lives. The outcomes are not what you need to see. And so there's a real need for policymakers to change the way in which they finance health. So, and they need to look at that now, not in 5 years' time, and not wait for a national health insurance to emerge in the course of time. There's stuff to be done now. So I just want to say that this is the picture, right? So we've got preventable diseases, and the health system is not geared to do that. So what you don't want to do is repeat that for next year, because you won't have a different outcome. So there's a need to change the financing model so that there are more cribs, there are more beds, there's more equipment, and so on and so forth. So those are the immediate things that can be tackled in order to save the lives of children. That's our next generation. That's the future that we're looking at, right? So it's both a moral issue and it's an economic issue. And I would put the moral issue first, as we should. So that's what you're looking at. Immediate things, steps to be taken, medium-term steps taken, and then longer-term ones. And let me turn to the longer-term steps. Africa has one pediatrician for every 200,000 children. Okay. And I just want to wrap my head around this number. One for 200,000 children compared to one per 1,400 pediatricians, per 1,000, sorry, let me say that again, compared to one pediatrician for every 1,400 children in high-income regions. So 200,000 children in the case of Africa, and 1,400 in high-income regions. The question is, if you can just, for the first time, just to reflect on the statistics. Is this true for, in the case of Wakabebe, for East and the Horn of Africa, and in the case of Ashraf, when it comes to South Africa? And then we'll talk about what's to be done to address that gap. But just to reflect on those statistics, first of all. Wakabebe?
I think that I might not know the exact statistics for my country, but it's not far from this number in general. When you talk about East African countries like Ethiopia, Sudan, Somalia, so the number of pediatricians is quite very low. And it's not far from 0.5 pediatrician per 100,000, which is a critical one to give specialized care. The healthcare the force is very, very critical. Like even if you're lucky and have the infrastructure, without the human healthcare force is nothing. So I think what we need to do is to train as many more pediatricians. And in fact, we need to go also to the specialist care. In fact, these hospitals are tertiary hospital, referral hospital, let alone with the number of pediatricians. This hospital needs subspecialists in a good number so that to give a quality care for these children. So I think the first thing that maybe that will be the next question, but I think we cannot run the emergency system or the healthcare system without people. So
absolutely, yeah. So Ashraf, could you reflect on the same issue about whether those numbers reflect what's happening in the case of South Africa and Southern Africa, but also what's to be done about it? And what's to be done about it is obviously education and training, as Wakabebe has pointed out. Just to say that this is to be paid for by national governments. This is not to be paid for by donors. It's a national ministry responsibility to do that. And the question of putting in place a pipeline for training is an issue you know well about. If you can just share with us what you think ought to be done in terms of education and training as a long-term strategy to fill this gap.
Yeah, no, absolutely. So Southern Africa is not much different from the rest of the continent. Obviously, you have certain parts of the country. South Africa is better resourced, and so the numbers will be better, but not nowhere near the high income countries of one pediatrician in 1,400. So we're more closer to the continental average number. I don't know the exact number, but we still are certainly have a huge need for pediatricians, specialists, and subspecialists that just not meeting the need in the country. But I just wanted to add that I think that what the healthcare system needs for the improvement of healthcare for children and survival of children is even more than just training specialists and subspecialists. I think we're at the kind of at the pyramid. There has to be a whole investment in the base of healthcare workers that care for children. So from nurses, from allied healthcare professionals. There'll never be enough pediatricians in any country, and pediatricians on their own and specialists on their own won't make a huge difference to the kind of child health survival if we don't actually build a whole healthcare force. And it's something that, as you said, training is what we need. Training is what many of our countries are already involved with and can do more, but it's for the lack of funding individuals into these posts. But there is of these hospitals that were studied, 19 out of 20 of them are affiliated with a medical school and a university. So it's involved in training of healthcare workers. And so there is the capacity in Africa, certainly, to train Africans. across the continent in healthcare services, where they don't necessarily have to go abroad or go across, leave the continent, but there has to be a huge investment across the board in training, from specialists right down to the childcare worker at a clinic level.
Absolutely right, Ashraf. And now you raise the question about leaving the continent. That's one thing to train your professionals. You also have to keep them, right? And you keep them. The retention of health professionals is a big issue, partly because they get actively recruited often by other agencies globally, but also because their conditions of work are such that it becomes really tough. So if you could, starting with you again, I should just comment on that story about the retention strategy, conditions of service. Because of you raise the whole of health that has to be not just the pediatric element. That's one aspect.
Yeah. Retention is such a complicated matter. It's on the surface of it, obviously, increased remuneration is what also drives a lot of people. But if you talk to most people that are healthcare workers in these countries, if I talk to colleagues and so on, they don't want to leave. They want to work in their countries. They want to stay in their communities. They want to make a difference. But if there aren't the posts, the jobs for them, and if the conditions aren't favorable, there's almost like a vicious circle that then gets created. If there's a smaller workforce carrying a huge burden, people get burnt out, and then they inevitably leave. So it has to be looked at in a very holistic way, apart from just what's the remunerative package that a healthcare worker is going to get. What kind of support systems are there for? Is there sufficient numbers of healthcare workers in a particular area? Are they getting kind of support to do their jobs? Are they getting recognized for the work they're doing? Is there career progression? So there are ways to really investigate what would keep people home and work in these places, because most healthcare workers go in and train to kind of serve the community, and most of them want to serve in their community. My sense is in Africa, and it's just that the conditions make it really tough and actually push people out the system. So what I'm saying is it's more than a pull factor, it's a push factor that takes people out of the system. And we've got to think of both. What is it that can keep people?
Yeah, I mean, there's a kind of an obvious list of interventions that can help. I mean, it's not rocket science to figure out how to improve conditions of work. So that's something that we clearly need to take further and think about. And then actually just there has to be interventions on that front. This is a long-term challenge that we're facing, and it's a long-term issue. When I was in the South African Parliament in the Health Committee, we looked at that issue, and many others have. So if I can turn to the other element around infrastructure, Worker Baby, if you can comment on what what are the most common infrastructure challenges. We've mentioned some of them, but think about what the challenges are and how they actually affect the day-to-day operations.
Yeah, in terms of infrastructure, so even in this paper, what is strikingly shown in this paper are like blackouts. So more than 85, like close to 84% of the hospital, they experienced blackouts in terms of electricity. And you can imagine a tertiary hospital with like 7% of them, they were experiencing daily blackout. And in this hospital where ventilators, like there are so many equipment, they need electricity. And in fact, it's not only the blackout, even the voltage fluctuation might also affect the ventilator or other machines that needs stable electricity. And in terms of like giving a quality of care, that this blackouts also even interruption, voltage fluctuation will affect the quality of care for these children. And some of the equipment or infrastructure that needs stable electricity might be affected by a problem with electricity. The other infrastructure, in fact, was mentioned is a water supply, and close to 58% of the hospital, they do have unreliable water supply. And in a hospital where there is no water, like you can imagine how to do infection prevention. Like simple hand hygiene will be difficult. Laundry, sterilization, you can name it. So in a hospital where there is no water, very difficult to implement infection prevention. And when the infection prevention is disrupted, then in so many literature, the hospital-acquired infection is now increasing in this hospital. So we can draw a horizontal line where there is no water, there is no infection prevention, and then will be a high rate of hospital-acquired infection that will increase the morbidity and also the mortality of these children who need care and come to our hospital, but we're not able to give the safe care that I can say. So I think these are the major infrastructure limitation and a low-hanging fruit that can be easily fixed if there is a will from the government or any supporting organization to fix this problem, this infrastructure in this hospital.
So you're quite right, it's low-hanging fruit. The problem is well recognized. The problem has catastrophic consequences. People go to hospitals not to get ill and to get, and to lie there in beds for longer than they need to because of this. So it's unmanageable actually for anybody working in hospitals that are properly functional, that you have these infrastructure challenges. It's not rocket science on how to fix it. And it is simply a question of setting aside enough budgets and appointing a corps of engineers to actually take care of it. So, there's no science problem or engineering problem to solve here. It's known what the solution is, so it just simply needs to be implemented. So, and then that's a question of political will, and it's a question of a national ministry saying, this is important, get on with it. Ashraf, you live in a world where Johannesburg right now does not know how to actually source sufficient clean water in that metropolis, and also has now a history over the last 10 years of blackouts, which runs by this euphemism of load shedding, which I think we should stop speaking about. They're blackouts. That's what they are. So if you can just comment on that issue for us, just given your work environment presently.
Yeah, so our electricity problem in South Africa is in the last a year or so has like turned around quite a lot, and we're not facing the sort of load shedding or blackouts, whatever you want to call it, as we were even a year ago. So we're not facing the same levels of challenges that we were, as I said, just a couple of months ago with blackouts and so on. But I think that just going to the study and relating it to the issue of electricity, what we found in the study was that 100% of the hospitals had generators. So 20 out of the 20 had generators. However, many of them had to use their generators weekly and on a very frequent basis, which just points to a real infrastructural failure and of the systems in terms of stability of electricity from the grid. So it does point to a real systemic problem. And I think that, it's also something that we've got to look at very critically and invest in across the continent in terms of energy supply as well as, the water supply. You mentioned water in Johannesburg and the kind of problems that we're having with sufficient water across the hospitals. That's an ongoing challenge. And I think, again, when we talk about low-hanging fruit, this is where having boreholes in every single hospital, several boreholes to kind of overcome this challenge is something that needs to be done as a matter of urgency.
Thanks very much, Ashraf. So could we turn from infrastructure to dealing with public health emergencies? So if you can just comment on that, Wilkabeba, about the capabilities of hospitals, not only to take care of routine matters, but to deal with public health emergencies. Can they surge? I would imagine there would be a great difficulty in that area, but if you can please comment on that.
Yeah. This part is seriously weak or dangerously weak, I can say. Just start with the simplest one, like isolation. When there is outbreak or pandemic or any catastrophic health effects happen, the first thing that we can think of like isolation, and like only one third I'll say of this hospital have isolation SOPs, so the rest they don't have, and less than 20%, close to like 17% have proper isolation room. It doesn't like it can. Most of them they have one or two isolation room, and with this number of isolation room, if patient arrived, any patient with infectious disease arrived to the hospital, it would be difficult for them to isolate, because most of them they don't have the SOPs, and also they don't have the room to isolate patient with infectious problem. And the other things that we can see also, like hoarding patient. Those, for example, these children with similar problem, with multi-drug resistant organism or any other similar problem, if there is a place to hoard them and isolate them, similar infectious problem will be one of the strategy, but only 55% of the hospital can hoard patient. And in terms of like disaster plan, less than 50% of the hospital have disaster plan, and having the disaster plan is something that we can appreciate, but like only a third of them have practiced it, like they did the disaster simulation. So if the health professional are not able to practice or do the simulation, it would be difficult for them to do it when the actual emergency or outbreak happen. So COVID come after this assessment, and in fact we have seen this problem, I can say, in my hospital also. So I think the health system is very fragile in terms of emergency and outbreak preparedness, and almost I can say that we are praying not this type of thing to happen at this particular time. I can say, like, still, yeah, that's what I can say.
Yeah, so given the pattern around pandemic and epidemic outbreaks, it will happen. The question is just when and what the pathogen is. It's really as simple as that. So preparedness is really important, and for hospitals to have the capability to scale up to deal with emergency is something that should be thought through ahead of time. So you're quite right. So you need a disaster plan, you need to stress test that disaster plan, and then you need to act on the results of that stress test too. Having the plan and ticking the box is no good. Having the plan, ticking that box, and then stress testing is an important thing, but it's not enough to check that box either. You actually need to act on it, and the policymakers have to invest money into improving responses. So, Ashraf, I'm sure you would agree with that assessment.
Yeah, I was reflecting on the questions when we asked participants when we went to the hospitals. Remember, this study was done with a self-evaluation survey. It was just under 1,000 questions, about 958 questions that Usually the head of department of pediatrics had to fill with colleagues, and then we had a team from the research team go to the hospitals and walk about and inspect these facilities. And I remember talking to lots of colleagues in the various countries where we visited, and we asked them about the disaster plans and are they ready for any potential public health threat. And remember, we were asking them just months before COVID, so it did seem somewhat conspiratorial that we said, "Are you ready for a disaster?" And then a disaster did hit us. But what I was smiling about was that when we asked these questions about, "Are you ready for a disaster?" many of them looked at us very quizzically and said, "But what are you talking about? We're living in a disaster. We're living through a disaster every day when 75% of the hospitals have to put more than one child in a bed. 75% of the hospitals in your top tier hospitals in the continent have to put more than one child in a bed on a more than regular basis, some on a daily basis. Then you know we're living through a disaster. We didn't have to wait for COVID um, to have reacted or to be acting. So, you know, the whole notion of surge capacity just doesn't come in when you're working at maximum capacity 365 days of the year. Um, it's somewhat of a joke to have surge capacity under those situations.
Yeah. So that's quite right. So the question is not whether you can deal with disease on a routine basis. The answer is no. And the capability to surge is an impossibility given the current circumstances. So that clearly should just be underlined. So the question now is, what kind of recommendations would you make? Put on the table, and what would be the most immediate things that can be taken care of? What are the medium-term things that should be taken care of, and the longer-term ones? So, because we've got to start somewhere, and we have to turn this around. Not we, but there's
Absolutely.
the full network of implementers and policymakers would have to focus on this and then finance it as well. So what kinds of policy recommendations do you think would be the priority ones? I mean, there's a lot that needs to be done, but what are the priority ones? So just starting with you, Ashraf, and then over to you, Wakabeba.
Yeah, thanks very much, Wilmot. I mean, I think we've been thinking quite a bit about this since the papers come out, and also since we've seen the results of this that were much worse than we thought we would ever witness. And I think that, as you say, it's a multi-pronged thing. It's going to require action on many fronts: infrastructure, training, supply chains, etc. I think one of the more immediate actions has to be before we start, recommending to the policymakers and the funders of what to do, is to actually do another targeted, perhaps, review of what the state of healthcare services are now post the pandemic, post withdrawal of funding. Where are we? Are we worse? Are we anyway better in some places? I doubt it, but I think we need to take stock of where we are, because this is data that's sort of 7 years old now. And, part of the reason it took so long was, part of that was, I think, COVID, but I think another big part of why it's taken so long is just the capacity of healthcare providers who could report on this are so stretched that we can't even report on the research of the findings in these hospitals. So we need to we need to use data in hospitals, in healthcare facilities. We need to take stock of now beyond just these academic hospitals, but across the whole healthcare system, which is looking after children. And then there are low-hanging fruit that we can start addressing, like take advantage of the training capacities that these countries have to train more healthcare providers who are already in the system, but also start looking at the infrastructural issues we talked about that have knock-on effects in the cost of running healthcare services. So as Wakabeba talked about how electricity, an unstable supply of electricity, starts affecting all your equipment and the costs. So there's a number of things we've got to start looking at quite urgently, actually. And one of the things that I just wanted to highlight that I'm not sure, but maybe we will come to, is that I'm not sure that many people realize that our continent has a really high proportion of children. The proportion of children on this continent is 40% of our population is under 15 compared to world average of 25%. And it's set to grow. So by 20, right, we're just under 600 million, 593 million children under 15. And when we get to 2040, that's going to grow by another 150 million. So we have a demographic tsunami facing us. And that's why there's an urgency to this.
Yeah, that's quite right. So our population pyramid is a bottom heavy, as they say. It looks like a triangle, and it's ought to be also, of course, the widest in the middle of that structure. So yeah, so we've got a young population, and we'll continue to be young and grow until fertility levels decline. So that's what we need to deal with, and that's an asset. That's an asset to young people. They energize economies, they what have you. And right now, we are not looking after our asset. So, Wilke, your view on the priorities policy-wise?
Yes. Yeah, I do agree with the low hanging that's already mentioned by Asha. So reliable power and water supply. The other important thing in this evaluation is the PICU and neonatal ICU. So like around 12 hospitals have pediatric ICU and 12 has neonatal ICU. And I don't know, maybe this number has increased, but in this tertiary hospital, in the top hospital in this area, even some of the hospitals, they don't have this critical care services. So expansion of critical care is one of the things that can be the immediate priorities. It's not only expansion of the critical care, even those who have critical care, there was a shortage of mechanical ventilation. Even the median number of pediatric ICU is 6 in a big hospital caring children. So these hospitals are taking referral from all over the country, and they have only 6 pediatric ICU, and the number of also neonatal ICU is very small. And in terms of like ventilator, they have like 4 ventilators, and one of the ventilator is not functional. In neonatal ICU, only the medial is 2 ventilator, one is non-functional, and we can see how the shortage of critical care, and these children are not getting critical care services. So the other thing that we can also prioritize is like equipment maintenance system. There are like equipment like ventilators, but not working. In a pediatric ICU where only 4 ventilators and one is not functional, means one force is not functional, and like you can see the burden of the healthcare professional working in that ICU to prioritize critically sick children. So that's also immediate priorities that we can mention of. Oxygen system, like 41% of the hospital have reliable oxygen, and essential supplies also. Like there is also significant problem in having supplies, essential supplies like antibiotic, oxygen, or like very critical supplies are also not available in most of the hospital, and massive workforce training can be done. Like when it comes to my country, Ethiopia, the last I can say 5 years, there is expansion of residency program. And also like in terms of medical education, the so-called flooding system worked for my country. Now the number of general practitioner compared to the healthcare system is, I can say, quite good, although there is still high attrition rate. Like this workforce are still going outside for several reasons. The number of pediatricians is increasingly like the number is increased in the last 5 years, because from 3 universities having residency program, now I think 6 or 7, I can say 7 universities, medical universities are now conducting residency program. Still, we need to work hard in terms of expanding massive workforce, but still it can be done. So these are some of the immediate priorities. I do agree with another assessment. The tool is available. The CHAMP tools is available. It can be used for assessment of this hospital. Again, also even having representative data. Also another thing that we can think of, and use the existing tool like WHO Hospital Emergency Response Checklist or Essential Emergency and Critical Care. So we can use this tool and also assess, and based on this recent data, we can also have recommendation to the government and also the ministries. Thank you.
So no, thank you very much. So that was a really good outline of what needs to be done. We've had some questions put to us, and we've answered most of them. In the meantime, the one question was, what are the critical and easiest corrective measures to take to remedy the situation? We reflected on that. There was a question about electricity supply, its independence and stability. We also reflected on that. And then there was one question about how many hospitals in West Africa were part of this research. Ashraf, I know there were West African hospitals part of the study.
Yeah, certainly there were West African hospitals. We had colleagues in Nigeria, Liberia, Ghana was involved. So at least those 3 countries were involved. So West Africa was certainly included.
Okay, so colleagues, let me tell you, I really appreciate the fact that both Ashraf and Worker Beba, who are both practicing pediatricians and physicians, took their time to spend with us and to reflect on that direct issues associated with what's happening in children's hospitals. But a hearty thank you to our panelists for joining us today for a very productive and very extensive study and discussion. Thank you also to the Pandemic Center, who helped put this event together, to Bentley Holt, to Michael Mitchell, Leah Lovgren, Amanda Kogan, Carly Gasker, Aaron Johnson, Andrea Ulig, and Alice Im. To stay up to date on future sessions, please use the QR code on screen to access to our link tree. There you can sign up for our webinar mailing list, catch up on past recordings, and explore other resources like our weekly tracking report, which includes updates on topics like mpox, measles, and emerging global outbreaks. After the recording, a recording of today's session will be available on our events page on our website, along with other previous webinars. Follow us on social media for updates. And please feel free to reach out with any questions or suggestions that you may have. We'd love to hear from you. Thank you very much. We are all adjourned. Please stay safe, be healthy, and stay engaged. This is the start of a process, and we will be in touch with you heading into the future. Thank you very much.